Good morning. Thank you, Chairman, dear colleagues. These are my disclosures. We know that there are several factors involved in the sphincter dysfunction after radical prostatectomy. Due to the healing process of these anatomical mechanisms produce that the continence is progressively restored during the follow-up of our patients. But this is very important. In this healing process, there are two different periods. The first one is the healing process, when the continence decreases progressively during the first months, and after there are an established period in continence in which there are no change in the rate of the incontinence. The key points of this, both periods are this one. The first one, the spontaneous healing, there are a high rate of incontinence, and we know perfectly that the incontinence alters quality of life. And we know also that the perioperative counseling of the patient, speak with the patient, has a positive effect of this patient. In the established incontinence period, the most important thing is to know the time for a surgery and the degree of the continence to decide the type of the surgery. The consensus in the guides is that the established period starts around the 12 months after surgery. But there are some papers and authors that publish that there are a delayed improvement between the 12 and 24 months after the surgery. The problem with the literature, there are some pitfalls. The first one, the wide range of the continence definition. This is a problem, of course, and these studies are based on questionnaires or only in the number part. So the aim of our study is assess the incontinence based in 24-hour PAT test in order to, one, offer an accurate prediction of the expected outcomes, expected results to our patients, and offer the best surgical option in the best moment. We include patients, of course, with 2 years of follow-up after radical incontinence, obviously at the first year, and will refuse any type of surgery at the first year. This is our schedule. All patients perform pelvic floor muscle training 3 weeks before the radical prostatectomy, and we do an continence assessment 1 week, 6 weeks, 3 months, 6 months, 1 year, and 2 years after the surgery. This continence assessment, prospective, is performed by a nurse not involved in the surgery, not involved in the treatment. Any factor that alters anatomical restitution problem is exclusion criteria, like a radiotherapy, brachytherapy, focal therapy previous to the surgery, and of course, surgery complications. This is our results. At the first year, we have 639 patients, and this group, 32% of patients has continence different from 0, no cure patients. During the first year, our period of study, we exclude 93 patients, mainly due to incontinence surgery or salvage radiotherapy. So our group of study was 114 patients. This is the first date. It's important to see that in this group of patients, there are no difference between the PAT test in the first year and in the second year. And probably this is the most important date. Only 14 patients at the end of this period are dry, 12% of the patients. And if we take in account the difference in these two groups in the first year PAT test, 24-hour PAT test, also there are no difference in the PAT test in both groups. Probably it's better to see this box plot. As you can see, all patients with PAT test, there are no difference, and the range of the patients cured at the second year is minor. Okay, And this is the difference of in the first year 24-hour PAT test, depends on the PAT test. 9 patients, in 19% of patients with first-year PAT test below 20 grams was cured at the end of the period, and only 2 patients with PAT test over 50 grams were cured at the end of the period, and no patients with PAT test over the 150 grams. This is a spaghetti block of our series, and this picture show we think about this period. There are no changes. Remember, only 14 patients change the PAT test, and there is a stability of the result during this year. So at least, finally, we check in both groups the risk factor of continence published in the literature, the most common age, body mass index, prostate volume, upper versus laparoscopy, and there are no difference in both groups in relation to the risk factor continence. So, in conclusion, based on the 24-hour PAT test, we have a best knowledge of the evolution of our patients in this period. We can say that the established incontinence period for us and for our experience is 12 months. And beyond these 12 months, the improvement is rare, and we start to speak with the patients about the surgery, about the type of the surgery, about the solution. Thank you very much.
Thank you, Dr. Collado-Zara, for a nice presentation with a clear take-home message. So I now declare your paper open for comments and questions from the floor. Please.
Do you agree that it will be important to show this data to the oncologic surgeons and not to the patients? Because what we see is that patients many times have delayed treatment because the oncologic surgeons, those managing the laparoscopy, say that they have to wait. I think this is a very sound data for immediate or very advanced intervention and not just waiting. Do you agree to that? I congratulate you because it's raw data showing this. There's no reason to wait.
Yes, I agree. For us, it's very important this is scheduled because the patient is conscious during the follow-up of the incontinence, the problem of the incontinence, and there is a solution because the patient speaks with the nurse. We check this 24-hour PAT test and the consult, and the patient knows that this is a problem and there is a solution for these patients. Of course, we need to speak with the oncology, urology, of course, because for us, it's very important the patient knows the PAT test, the incontinence, because in this case, ask for a solution.
Okay, thank you.
Please.
Thank you. Jerry Blavis from New York. I enjoyed the presentation. Is there anything that we can learn in the intermediate period between maybe 3 months and 6 months? Because there are some patients that have profound incontinence and they're told to wait a year. I mean, is there anything that, and they get very frustrated, some of them, if they're not seeing progress at month 2 and 3 and 4 and 5 and 6 and 7. Do you think there are times that we can and should intervene, or at least recommend intervention earlier than in a year?
Yes, this is not this paper, of course, because this paper is this period. But you can see we have a lot of experience between inside the first year with our days. We present this data at the last European Congress. If you have a 24-hour PAT test over 400 grams in the 6 months, with our days, we can speak with the patient because probably this patient needs a surgery. For us, at this moment, we start to speak with the patient about around the 24-hour PAT test in the 6 months. But for us, it's a good idea to present these days because there are no information about this period in the literature, only in the number of PAT tests, and the number of PAT tests cannot do a solution for this problem.
Thank you.
If you have a patient with 20 grams, you can wait, but if you have 200 grams is not necessary to weigh.
20 grams in a woman would be considered cured.
But this is not woman. This is men have the radical prostatectomy.
Thank you, Jerry, and thank you, Dr. Colado-Sierra. Sharif, do you have any comment?
No.
I just want to ask you one thing. You mentioned that post-operative complications constituted exclusion. What complications were there? Were the cutoffs based on a Clavian-Dinder degree or what?
The complications are exclusion criteria for this paper.
Yeah, you mentioned
not
that.
for our work.
What kind of complications are we talking about? Was it because if you exclude everyone with Clavian-Dinder 1 and 2, you wouldn't have any patients to study?
Bladder neck obstruction, delayed bladder neck obstruction, stricture urethra. These are complications to alter our PAT test.
Okay. Well, thank you very much.
Thank you.